This is Solid 2 is focused on clinical applications. And tonight we've got two really hot topics that you're going to see a lot of. One is hyponatremia, and the other is diabetic ketoacidosis. And surprisingly, they can actually overlap each other here a little bit. So first I have Dr. David Levy, who is an assistant professor of clinical medicine at the University of Rochester School of Medicine, and he is a nephrologist. So Dr. David, I'll turn this over to you.
Thanks, Dr. Good. I appreciate it. And so just a couple of caveats for tonight. The first one being if you have 10 nephrologists in a room and you ask them to diagnose and treat hyponatremia, you'll probably get 20 plus opinions. And so there's a lot of ways to kind of tackle this. What I put together is a brief general review of how I approach this and how I've spoken with others, nephrologists around the country to kind of how to best tackle this, but you will undoubtedly see many different ways of negotiating this. The second caveat is that hyponatremia in 20 minutes is a challenge. And so we won't get through all the slides in detail, but we'll make them available after the talk. And that way I'll be able to just pass over some of them, but you'll be able to review them later for further reference. And so we're going to start off with a case, and really it's one case, but it's a complicated case. So I said to myself, how can I make this the most complex possible hyponatremia situation to kind of go through what we worry about and how to kind of approach that. So this is what it is. So this is more or less true. I made it a little bit more complicated than when I really saw her. But anyway, so a 76-year-old female, significant past medical history of stage 4 small cell lung cancer. I'm currently undergoing some cocktail of chemotherapy. Comes into the ED with symptoms of fatigue, dizziness, nausea, vomiting, and poor oral intake. Blood work is drawn, which shows the following labs. Serum sodium is noted to be 119, potassium is 2.8, glucose is 97, BUN is markedly elevated, 160, creatinine is 3.5, serum osmolality is 301, urine sodium is less than 30, and urine osmolality is greater than 750. And the labs done 2 weeks ago were completely normal. All the labs here normal 2 weeks ago. So before we tackle how to approach this particular case, let's break down hyponatremia a little bit further. And so one of the important things to understand with hyponatremia is just salt and water balance itself. And so we often use the words like serum osmolality or osmolality, and so which is true and a valid term, but what's more important to understand is the effect of osmolality or tonicity. And this is not
This fatal word name, Alex. No, I'm sorry.
So anyway, so the effective osmolality or tonicity is an important piece when it comes down to understanding how solute and water moves between the intracellular and extracellular space. And so the serum osmolality is all the solute in the system, all the solute in the blood. And that's osmoles that are able to freely move between compartments and osmoles that can't. So, and the compartments are the intracellular and extracellular space. So sodium, BUN, glucose, everything all put together, that's your total serum osmolality. But then your effective osmolality or tonicity, those are osms that can't freely move between the intracellular and extracellular compartment, and that forces water to move between those two spaces. And the reason for that is because of physics, which I don't love, but we have to deal with it, is that the osmolality inside the cell and outside the cell has to be the same. So if something happens and that osmolality inside or outside the cell changes up or down, the osmolality of the other compartment must also change. And therefore, either water has to move to make that change equal, or the osm has to move. So when it comes to effective osmolality, these substances cannot freely move between the cell and outside the cell. And the two big ones, and for hyponatremia, the biggest one is sodium, and potassium is going to play a role as well in this. But keep that in mind as we go through further into the discussion. So I've again underlined, bolded here to make this to really stress this point, because if you understand this, you are leaps and bounds ahead of many practicing physicians who don't really appreciate just how important tonicity is when it comes to salt and water balance. And the next really important concept is what's called the Edelman equation. And this equation states that the plasma sodium is proportional to the total body exchangeable sodium plus the total body exchangeable potassium over total body water. And these exchangeable sodiums and potassiums, you can't measure these. These are everything in the muscles, the bones, the intracellular fluid, the extracellular fluid, everything combined as these exchangeable values. And the reason why this is important is if you look at plasma sodium, there's only 3 things that could happen to cause hyponatremia. So for the plasma sodium to go down, either the total body sodium goes down, or the total body potassium goes down, or, which occurs in 90+% of the time, the total body water goes up. And if you think about it, if your total body sodium goes down low enough that you cause hyponatremia, and it can occur, there are salt wasting nephropathies, there's adrenal insufficiency, etc., you're in pretty serious trouble. And you need pretty serious rapid treatment, or you won't do well and people will succumb to death. And so there are salt wasting disorders, there's genetic disorders, adrenal insufficiency, but that's a small amount of hyponatremia. If you look at potassium, yes, if you bring your potassium low enough, you will lower serum sodium. But if you think about it, if you bring your total body potassium stores so low that you're causing hyponatremia, you're also going to get severe EKG abnormalities, arrhythmias, and you also aren't going to survive very long. So the vast majority of the time when people get hyponatremia, it has to do with too much total body water. The other thing to keep in mind is if someone comes in and they're hyponatremic and they're hypokalemic, so sodium is low and their potassium is low, if you replace potassium, you will raise their sodium. That is a very, very important clinical point. I promise you will see this throughout your career. Someone will come in, alcoholism, malnourished, whatever it is. Their sodium is low, their potassium is 2.5, and the ED is starting saline or plasmolyte, whatever fluid they feel like giving, and now the sodium starts to now rapidly shoot up. So the answer in that situation is not to not replace the potassium, you need to, but to understand that the sodium will rise rapidly. So you may want to do something in addition to that, such as giving D5W at the same time to counteract the rapidly rising serum sodium levels. And so I bring up this slide here. This is my very crude artistic skill here. I'm trying to just show the different compartments and how fluids move between the spaces. And so in the big red box here, that's your vascular space or intravascular space. And that's going to be the site of all diuretics, dialysis, hemofiltration, whatever you're doing to remove fluid from the body, unless you're doing a direct tap, is going to target this space over here. And then you have this blue box down here. That's your extracellular space. And that's where you're going to have your extravascular space, sorry. And that's where you're going to have all that extra fluid. That's the edema, the ascites, all that extra fluid we're trying to get rid of. And what happens is there's this plasma capillary refill rate that we can't measure it, unfortunately. And so what happens is, depending on what this rate is, if this rate is really good, people can get high doses of diuretics, they can get lots of dialysis, and they can get lots of fluid off, and they do fine. And then you'll take someone else who has a very poor plasma refill rate, who has a blood pressure of 210 over 120, you put them on dialysis, you take off a little fluid, and their blood pressure just tanks. And you're saying, what's going on here? Their blood pressure's up, they have fluid everywhere. What's going on here? Why is their blood pressure dropping? And so this is an important thing to keep in mind when it comes to fluid and salt balance, just in terms of that we cannot measure this rate, but this rate is very important when it comes to refilling that intravascular space. The other piece, which is often forgotten, especially in the allopathic world, is just the lymphatics. And a story for another time is just how if you forget about the lymphatics, you can get yourself and your patient into some serious trouble. So especially as DOs, we are trained more about the lymphatics than our allopathic colleagues, and they really are absolutely important, vitally important when it comes to fluid balance and making sure that you're appropriately taking care of your patient's fluids needs. Okay, so what happens when we have hyponatremia? So here's my normal brain cell. Inside the cell, 2 parts water, 2 parts sodium. Outside the cell, 2 parts water, 2 parts sodium. Osmolarities are 290 each. And everybody's happy. And then all of a sudden, sorry, I'm just going to move this zoom over here so I can see. Okay, so all of a sudden something happens and we get hyponatremia. So now we have extra water, we have 4 waters here, 2 sodiums outside the cell, 2 waters inside the cell, and 2 sodiums inside the cell. And then what happens here is because you have the extra water outside the cell, the osmolality now drops down. So let's say 265. Compared to inside the cell, it's 290. Now, this is an unstable condition. This can't last very long because you can't have different osmolalities intracellularly and extracellularly. So, sorry, let me just go to the next slide. Okay, so then we get to stage C. So what happens here is over time, because there's more water outside the cell and because sodium is an effective osm, i.e. it can't move between compartments, that's at least not freely. And so what happens is the only way to bring these osmolalities closer to each other is for water to move into the cell. And that causes the cerebral edema. And that's where you start to get symptoms of nausea, vomiting, fatigue, headache, etc. Now, over time, the brain, although not as smart as the kidneys, is not stupid either. And over time, the brain says, I don't like feeling this way. This nausea, this vomiting, this dizziness, this is terrible. I got to do something about it. So over this time period of approximately 48 hours, the brain will start to eject out GABA and other neurotransmitters, other osmolytes. What that's going to do is it's going to now drop the osmolality down inside the brain. And so now the osmolalities are going to now equal each other inside and outside the brain. And so here we are, osmolalities are 270 inside and outside the brain, 3 waters, 2 sodiums, 3 waters, 2 sodiums. Everyone is reasonably happy, maybe some mild symptoms, but nothing too terrible. Now the person walks into the ED, looks a little volume down, gets 2 liters of normal saline or plasma, whatever it is. And so what happens now is the sodium is now rapidly corrected. The hyponatremia is rapidly corrected. In this case, it was an ADH-mediated process, and we'll go through that in a couple of slides. And so, but whatever the process is, when that hyponatremia is corrected, regardless of whatever caused it, if it's now been over that 48-hour period, what we call chronic hyponatremia, you now have a situation where water is rapidly moving out of the brain in response to the higher hyponatremia, in response to the higher osmolality outside the cell. And this process of water movement outside the brain after the neurotransmitters were ejected in that 48-hour period is what causes osmotic demyelination or central pontimyelinosis, a severe neurological complication from rapid correction of hyponatremia. So all this is to say that unless the patient is having severe symptoms being seizures, they're severely encephalopathic, you're about to intubate them, that kind of stuff, you have time, assume that it's chronic unless you know for sure that it's not, and take your time when treating hyponatremia. We treated someone with a sodium of 96 and a potassium of 1.8. Guess it was in the ICU, did fine, no problems whatsoever. It was a lot of long nights doing that, but you absolutely can do it. There's no reason to just rapidly correct these people. You're going to end up getting yourself into trouble. The only exception to this is someone who comes in with a severe hyponatremia, or not even severe, someone who comes in with an acute hyponatremia, usually marathon runners, someone collapses after a marathon, someone's at a party, college party, high school party, whatever it is, and they're doing drugs like ecstasy or MDMA, and they're very dehydrated, and that causes an acute hyponatremia. And those patients come in very symptomatic with seizures, lethargy, that kind of situation. That's someone who's going to get a rapid correction of their hyponatremia. But 99 times out of 100, if you're seeing the patient as an internist, it's going to be someone in this situation. If it's someone who's seizing with hyponatremia, they're certainly going to the ICU, and nephrology is definitely going to be involved. And so I'm not going to go over this slide in detail just for the sake of time, but this just talks about osmotic demyelination syndrome. It's bad. You really don't want it to happen to your patient. It's really bad for your patient. It's really bad for you. And be very, very careful with correcting chronic hyponatremia. And remember that 48-hour window. One thing I will mention is that cutoff sodium of 120. That's kind of your magic number. If it's above 120, especially 125, this is not really an issue. It's really those more severe cases of less than 125 and really less than 120. Okay, so briefly about the serum osmolality and osmolar gap. So the problem with this is that sometimes patients have a variety of things going on at the same time. And when someone has hyponatremia, more often than not, someone wants to measure a serum osm. But the issue here is the serum osmolality that you're measuring takes into account osms that are effective and non-effective osmoles. So things like BUN are not effective osmoles. Toxic alcohols are not effective osmoles. And so those substances, like our patient that I showed you before, can cause the osmolality to be increased. However, they're not effective osmoles. So if the osmolality is high and it's due to a non-effective osmole, the patient is not protected against overcorrection of hyponatremia, and you certainly need to correct it very slowly. However, if it's due to something like hyperglycemia, mannitol, IVIG, and other substances, those substances are effective osms, and therefore this problem over here doesn't occur because the osmolality, you don't get that problem because you don't get those osmolality differences. And so this issue is important because if you have someone who comes in and they are obtunded, they're fatigued and they're poor story and they smell like alcohol and they have a positive toxic alcohol screen and their osmolality is high and their sodium is low, right? Understand that although their osmolality is elevated, they still have hyponatremia and you still absolutely have to be concerned about it and you still don't want to rapidly correct them. Or the dialysis patient. We see this all the time in the nephrology world. Someone's BUN is very high, like the case I presented here, and they come in and their sodium is 115 and their BUN is 150, right? And if I measure their osm, it's going to be high. However, that BUN is not protecting them, and therefore you must treat them accordingly. And it actually gets to be a bit complicated sometimes in nephrology, but just keep that in mind that if you don't know what the substance is that's causing that increased osmolality, you have to assume that it's not an effective osmole and treat them accordingly. And so in terms of the broad overview of etiology of hyponatremia, I break it down to 3 major categories. You have the renal salt wasting disorders or disorders that are going to increase your renal, really truly a renal salt wasting condition, which could be an adrenal insufficiency, primary adrenal insufficiency. Thiazide diuretics can certainly do this. And there are some rare genetic kidney salt wasting disorders that you really don't have to worry all too much about unless you go into nephrology. Then you have the 2 really big bigger categories that you have to worry about, the ADH mediated and non-ADH mediated. And so what happens is there are baroreceptors in the aortic arch, and when the aorta is dilated out, they stretch out and they decrease ADH secretion from the posterior pituitary. But what happens is if you have less baroreceptor stretch, that inhibition goes away, and essentially what happens is you get increased ADH secretion, and that can cause hyponatremia. So if you have any situation where the effective intravascular volume is depleted, heart failure, cirrhosis, nephrosis, anything like that, yes, the patient is extravascularly volume overloaded, but what the kidney sees and what the hypothalamus sees and what the pituitary sees is intravascular volume depletion, and that's why you get hyponatremia in those situations. You also get hyponatremia from SIADH, of course. And so from a internist standpoint, you definitely want to keep these conditions in mind, as well as thiazides definitely can absolutely cause hyponatremia through a variety of mechanisms, especially in the elderly. So be careful in elderly patients who are at risk for hyponatremia. You may want to choose something other than a thiazide. And then the non-ADH mediated, this is going to be individuals who are eating that tea and toast diet, beer potomania, polydipsia. And the short reason for this is that the brief reason I should say is that you need solute to get rid of free water. So the more solute you eat, the more free water you can excrete. And vice versa is also true. So if you have someone who's eating melons and fruits and things like that, not a lot of protein, not a lot of solid food, they're going to be unable to get rid of that extra free water. And that's going to cause that's this non-ADH mediated hyponatremia. I joke with our fellows that because we see a lot of these patients, unfortunately, that if I ground up a steak in a blender and had them drink that grounded steak, it would treat their hyponatremia and they wouldn't be in the hospital. I would save ICU visits. And it's 100% true that this is a solute water problem. Unfortunately, a lot of times that's obviously not something you do clinically, but just driving home the point that you need solute to get rid of that extra free water. And so this is just talking again a little more detail about vasopressin or ADH. Again, the big thing I want that you guys to take away from this is just that this decreased baroreceptor stretch, such as when you have heart failure, nephrosis, etc., even diuretic use, if you don't have enough stretch in in the aorta, what happens is you're going to get extra ADH secretion, and that's going to result in hyponatremia. Just very briefly on urine sodium for the sake of time. So urine sodium is a reflection of dietary intake. So if you had bacon and eggs for breakfast and then you checked your urine sodium, it's going to be high. If you had coffee and black coffee and nothing else, it's going to be low, kind of thing. However, it's very useful in hyponatremia diagnosis because the urine sodium is also a marker or a measure of how much aldosterone is present. So assuming someone is eating a reasonable diet, if they have a low urine sodium and the cutoff is 30, that's suggestive that there's some sort of intravascular volume depletion. And so this can kind of help you when you're trying to tease out someone who has SIADH versus someone with intravascular volume depletion. So urine sodium and urine osmolality are the two important urine studies that you want to get with any hyponatremia case. And what I tell my fellows all the time is when we get a consult for hyponatremia, until they do the urine studies, there's really no point in doing anything else because we can't, unless it's a very obvious heart failure or something like that. And that's usually not what they consult us for, right? It's someone who's got a more complicated situation, and we need those urine studies to kind of see where we're starting with, what are we dealing with here, and what are going to be our next steps. And so again, this is just a little more detail. I will skip it for the sake of time. The numbers are there in terms of the cut points, 100 for urine osmolality and 30 for urine sodium. And again, the urine osmolality is a surrogate for ADH, and urine sodium is a surrogate for aldosterone. And using these two markers will help guide you as to what the cause of the hyponatremia is, and then accordingly how you want to treat that. And so in the last couple minutes, just very briefly, just the classifications of hyponatremia. So hypotonic hyponatremia, this occurs when the serum sodium is low and the measured osmolality is low. So that's kind of your classic hyponatremia that we all think about. But then there are things like hypertonic hyponatremia. And what happens here is the serum sodium is low, but the osmolality is high. And this can be caused by a variety of things, both effective and non-effective osmoles. So hyperglycemia, so someone who's got DKA, for example, and they're and they have severe hyperglycemia, that will cause a hypertonic hyponatremia, mannitol, IVIG, etc. And those substances do not cause the same water movements that we talked about before, and therefore you don't get issues with fluid shifting out of the brain. So if someone has hypertonic hyponatremia from something like hyperglycemia, mannitol, IVIG, you don't have to worry about rapid correction. In fact, when someone has DKA or just severe hyperglycemia in the hospital, no one checks it. Rarely do you check a serum osmolality. We know it's going to be high. You treat the hyperglycemia, the sugars get better, the sodium gets better, and no one really thinks about it. But this is the reason why you don't have to think about it. However, if you have a toxic alcohol or a very high BUN or other non-effective osmoles that will raise the serum osmolality, but they're not effective osmoles. And in that situation, you must treat this patient like a chronic hyponatremia and avoid overcorrection. And then the last category would be isotonic hyponatremia. So in this situation, you have a normal serum osmolality. This is also known as pseudo hyponatremia. And this occurs under two situations. One, you have to have a lab that measures sodium with an indirect method, which is some labs around the country, but not that many anymore. And number two, you also have to have something else going on that's artificially changing the proportion of the solid phase and the liquid phase of blood when they're measuring the analyzer. So there's set points of how much solid component and how much liquid component should be in the blood. If you have severe hypertriglyceridemia, severe hyperproteinemia, hyperlipidemia, etc., in the setting of indirect measurements of sodium, you could get the situation of pseudohyponatremia. However, it's rare because, again, you have to have a lab that doesn't measure direct sodium directly, and a situation where you have a rare condition causing this elevation in triglycerides, proteins, and or lipids. I'm going to skip this for the sake of time. I'm leaving it here for the reference. This came out back when I was a resident, which doesn't seem like that long ago, but I guess it kind of was back in 2014. It is an outstanding review of how to work up, manage, and treat hyponatremia. These are just a couple of pictures of their algorithm. It seems complicated, or maybe it does, maybe it doesn't, but it's really relatively straightforward. And if you follow this algorithm and you follow their approach, you will unlikely miss hyponatremia or treat it in the incorrect manner. And so this is just a brief slide about treatment goals. I'm going to skip this for the sake of time, but I put the numbers in there for you. Just that we don't want to do no more than 6 to 8 milliequivalent millimoles per liter within that first 24-hour period. And every other 24-hour period, you're going to aim for 6, trying to avoid overcorrection. Take into consideration potassium. If someone's hypokalemic, you got to give them potassium back. You're also going to have to give them some free water back as well. And this is going to be a summary slide of treatment options. Again, I'll skip for the sake of time. I'll leave it there for your reference. And then going back to our patient. So here we have a very complicated patient, pretty significant hyponatremia. Unfortunately, we see this pretty often. We have a very large cancer center where I am. And so we see this pretty commonly. Someone with cancer, metastatic disease, they're on chemotherapy, potassium is low. In this case, it's even more complicated with the AKI. So what she essentially has is a couple of things. So one, if you'll notice, a urine sodium is low and a urine osm is 750. And so if we go back to her urine studies, a low urine sodium with a high urine osmolality is suggestive of someone who's just very intravascularly volume depleted. But 750 is just a bit too high. In fact, I would argue she would probably have a higher urine osmolality if it wasn't for the fact that she had such bad AKI because her ability to concentrate her urine is now impacted. So let's say her urine osm really is probably closer to 1,000, which is ridiculously high, right? So this is more suggestive of someone with SIADH when you see someone with the urine osm that high, but the urine sodium is not consistent with that because in SIADH, you would have a normal serum sodium or a urine sodium greater than 30. So what this person has is a combination of two things. She has SIADH from paraneoplastic syndrome in the setting of her stage 4 of her small cell lung cancer. And she also has intravascular volume depletion in the setting of her nausea, vomiting, and poor oral intake in the setting of her chemotherapy. So I've taken care of quite a few number of patients like this, usually not with such bad AKI. What we do is give a small bolus of normal saline, kind of get them rid of that intravascular volume depletion state, and then work on the SIDH piece. But this is pretty much one of the most complicated hyponatremias that you will see. And of course, replacing the potassium. So for her, if seeing the potassium being that low, I would give her some potassium. I probably wouldn't give her normal saline. I would actually probably give her D5, some potassium, and watch her very, very closely. Because again, as you replace that potassium level, you're going to start to correct that sodium as well. I will stop there, and I think we're going to wait for questions. Is that correct, Dr. Good? Do you want to do questions now for this part?
I think if there's questions, you had a lot of slides there and we got 5 minutes. You did a really great job in covering a lot of information. So I'll leave it open to the students. If you have questions, just open your microphone and ask. While we're doing that, I think that this business of hyperaldosteronism and how do you kind of stretch that out in volume depleted patients who are coming in sick. Kind of want to just explore that. We're waiting for other questions there, David.
I'm sorry, can you say that again? So hyperaldosteronism and
So you have a volume depleted patient. They chronically have a hyperaldosterone state because things aren't simple when they get to the hospital.
Yep.
So you just want to address that, please.
How I would treat that, you mean?
Yes.
So I think it's really comes down to You want to balance out where they are when you see them and how much fluids you want to give them and what your goal, where you're trying to get them to be. So if they'll eat and drink normally for me, or at least to some degree, that's usually pretty decent enough to get them out of, a tough situation with their hyponatremia. Now, more often than not, they're not eating, they're not drinking, or they're sicker. So you do sometimes have to play with the fluids. But usually a small bolus, half a liter, maybe even up to a liter, will suppress aldosterone usually pretty quickly, for the most part, assuming they're not having additional losses through stool or vomiting or things like that. So it's kind of just balancing out how much do you use the gut, how much do you use intravenously, and the other thing to think about, and the problem we all face is that this is. Our labs are always delayed. No matter how good your nursing staff is, how good your lab is, right? It's always hours later. And so it's often always kind of trying to catch up based upon what happens. So making sure you're getting those labs very frequently is really, if you can do them Q3, Q4 hours, which is tough to do, that's really the best way to kind of see where things are and then adjust accordingly.
Okay. Any other questions? So I have another one.
Sure.
We have patients whose sodiums never seem to get above 135, right? They just kind of sit there. They're clinically fine. They maybe have multiple drugs that they're on for hypertension, and you hate to be messing around with it. What do you do with those patients?
Me personally, most often nothing.
Yeah.
And so I'm a firm believer that if it's more of a we're worrying about it and the patient's not having really a major issue with it, then I watch them. I see a lot of these patients in clinic, and we encourage solute intake, and we encourage them to eat more protein. And I have several patients who are strict vegans, and that also, of course, makes some difficult choices and decisions. But if it's on those lower ends, usually not much. Or if they're on an SSRI or something like that, and they have some SIDH, and nothing really bad's going to happen at those levels, especially if they're not very symptomatic. Now, if they're older and they're in the low 130s and they're at risk for falls, and we can argue, should we do some medication adjustment? But it's just really tough just because it's so hard to 100% know exactly. It's usually multifactorial. And the other thing that could sometimes happen is just a reset osmostat, and that's where the threshold for ADH is lower than it should be. So that 135 may be that patient's normal sodium. It's not normal, or that 134 would maybe not normal for everybody else. It may be normal for that person. So sometimes reset osmostat can be tricky in the hospital as well.
Yeah, I think that's really a good point because students will be seeing those patients are just chronically low and not to get too excited about it when they're clinically well from that perspective. Any other questions? Thank you very much, Dr. Levy. That was a
Thank you.
great presentation. And Kara, we're going to get those slides out to everybody, right? So they can review. There's a lot of good information in those slides. And I
Yes,
think
we
those algorithms that he presented will save students behinds, right? It's a good way to work through it. Okay, our next speaker is Dr. John Arthur. John is a resident in internal medicine, and he's the ACOI resident representative. And we're going to talk about diabetic ketoacidosis, another very common thing that we see in the hospital setting. So Dr. Arthur, take it away.
Hey, thank you, Dr. Good. Are you all able to see my slides?
Yes.
Perfect. Okay, so there's a lot of pressure after doing my presentation after a nephrologist, but I'll try to do justice. But DKA. So when we're typically thinking of this, back when I was a medical student, I'm thinking, what is the bread and butter of internal medicine? Dr. Levi already said one, hyponatremia. DKA was the next one. It is something that's quintessential for me, not only as a medical student, but throughout residency. I see this tons and tons and times again. So by the end of this lecture, I'm hoping you all be able to understand the pathophysiology of DKA, identify its clinical manifestations, interpret laboratory findings that are typical of DKA, formulate a differential of common etiologies of DKA, and ultimately applying these key principles in managing it. So back when I was a fourth-year medical student, I rotated at Orlando Health in the ICU, and there was a attending of mine that said this to me on a daily basis. A doctor is only as good as their understanding of pathophysiology. Now, this might sound a little extreme, however, there is some truth to this. So DKA, what I would say, is the quintessential example of this. If you understand its pathophysiology, you'll be able to apply through the reasoning behind patients' clinical manifestations, their biochemical workup, and ultimately how we're going to manage them. So that being said, I created a very simple diagram of the pathophysiology that took way longer than expected on the PowerPoint. So normal physiology, very simple. Insulin binds the receptor, allows glucose to come in. Through glycolysis, we ultimately get pyruvate. That pyruvate goes into the mitochondria, and through the Krebs cycle that we all hate, but it's very high yield, ultimately that produces an ample amount of energy. And because that glucose is going to the cell, those fatty acids there in the bottom right are disinhibited. They actually are unable to go into the mitochondria because we already have an ample amount of energy. So let's say now the patient with DKA, okay? So in DKA, of course, you have a deficiency of insulin. And I'm talking about an absolute deficiency of insulin. That's how DKA works. What happens is that as a result of that insulin not being able to bind to that receptor, glucose can't go in. We can't get glycolysis. We can't exchange that energy into the mitochondria. Ultimately, we need still some form of energy. So that's when fatty acids come in. Through beta oxidation, what happens is that you break up all those long chains of fatty acids, and that produces the ketone bodies, which produce energy, but it's not as efficient, and there's actually a lot of ramifications behind those ketone bodies. So those ketone bodies, there are three that are the kind of the main players when you think of DKA. Number one is the beta hydroxybutyrate. Secondly, acetoacetate. Third, acetone. So going from the bottom, acetone, it's a very volatile ketone body to the point where it actually could produce into a gas. That's actually the thing you smell when that classic Bohr thing of the fruity smell from those patients who are currently experiencing DKA. For beta hydroxybutyrate and acetoacetate, what I actually really want you to focus on is at the very end of that chain there, the carboxylic acid chain. So what happens is that they actually donate a proton, and by being negatively charged, they induce that anti-metabolic gap acidosis. So there are three things that we learned just now from this, very simplified lecture. Okay. So first off, glucose can't enter the cells. We're going to have a high amount of glucose. Secondly, we're going to have beta hydroxybutyrate and acetoacetate donating this proton, ultimately leading to acidosis. And lastly, just this buildup of ketones. Okay, so that helps us lead into now actually the diagnostic criteria of it. So on the left, patients clearly going to have pretty profound acidosis, most notably anion-metabolic acidosis. So pH less than 7.3, I will say typically we get this through arterial blood gas or a serum bicarb being less than 15 millimoles. Okay, you're going to have ketonemia, as those three ketone bodies already stated. All right, so typically you would diagnose this either by getting a serum beta hydroxybutyrate, which would be greater than or equal to 3. More severe would be greater or equal to 6. Or ketonuria, a moderate or large amount, which can just signify that clearly your body has a lot in your blood. And lastly, go figure hyperglycemia. So what happens is that I would say on average, people in DKA typically have around 250 to 500 milligrams per deciliter. Once you get above that, that's when you start getting to that HHS territory, which is associated with type 2 diabetes. I will say, though, in the ICU, actually, I've seen plenty of people who've had, let's say, glucose about 1300. So definitely, it's not just exclusive to type 2 diabetes. So what I'm going to do real quick is now utilizing this pathophysiology now, we're going to actually apply this to a case, okay? By doing this, it's really going to drive home the point of understanding why we get certain tests and ultimately about the clinical manifestations and the management that will do for them. So we have a patient here. I very cleverly explained this is Miss Sydney Sweets. So this is a 24-year-old female, history noted for type 1 diabetes, presents to the ED, chief complaint of nausea, vomiting, and abdominal pain. She's been fatigued, feeling unwell the past 2 days. Furthermore, she notes she stopped taking her insulin these past 3 days due to feeling nauseous. Okay, so typically then what I would ask is, what else should we ask? I know there are a few medical students on. I actually would give you, 30 seconds if you want, just to come up with the response. If you can either, participate in through the chats, saying it to me, anything we can do. If not, we can proceed. So I'll give you some moment.
Is she pregnant?
No, she is not. Great question.
Has anyone been sick in the household?
No, she lives by herself. She works at a diner, however, and she was saying that maybe some people, it's been the flu season, maybe some people have been sick, but she's not entirely too sure about that. Okay, so those are actually some really good questions. So what I can help actually prelay a little bit more is that so she has a history known for depression. Okay, surgery, she's had an appendectomy, age 17, no complications. Medications, she takes a long acting, so this is glargine 20 units at night, and aspart 5 units with meals. And she also takes something for her depression. It's a very mild, minor dose of escitalopram. It's 5 milligrams daily. For allergies, like every patient. I think I had a allergic reaction to penicillin. My mom told me back when I was a kid. I think it was a rash. And lastly, regarding the social history, no tobacco, recreational drug use. She drinks occasionally, typically with her coworkers. I would say 2 cocktails per week. She's in a monogamous relationship with her boyfriend, intermittent condom use. Again, works as a server at a diner, and she currently lives alone. So, how about, obviously, spoiler alert, this is DKA, but can you think of actually some differential diagnoses we can apply to this patient? Obviously, we're going to walk in, we might not get that history of type 1 diabetes. So it's always kind of nice to put on our internal medicine cap. What would you all say?
I would still think like a community acquired GI bug, like a norovirus or something, right? She works as a server, she's touching lots
Hmm.
of things. We don't,
Nice.
so
Yeah.
we can't prove how good her hygiene is.
Hmm. I would say that would be like, obviously something I would run on top of my head as well. Any others? Okay. So when we're thinking about certain differentials, there's so many. So I would say she has abdominal pain, typically a ED, you think, okay, this is pancreatitis. Gastroenteritis, kind of like what you mentioned, Megan. Is this viral? Is this some kind of bug that they picked up? Pyelonephritis, UTI, it's abdominal pain. Do they have a kidney stone? Is there toxic ingestion? Or, and you were very astute about this, is there any pregnancy related complications if they were pregnant? And there's just so many more. So the important thing is though is clearly we can easily develop a very easily differential for this because the symptoms overlap. So actually looking specifically at DKA of its clinical manifestations, I not no longer going to have really any kind of diagram that I made myself. I'm solely going to rely on other charts now because I can't do any more justice than the American Diabetes Association. So on the left here, we have more of the early signs of DKA. Okay. Typically, patients would feel very thirsty. If you think about it, if you have a high amount of glucose, that glucose has to go somewhere, and ultimately you're going to urinate it out. So I would say a lot of patients that would ultimately get admitted I would be about 6 to 8 liter deficit, so extremely dehydrated. Okay, and as a result, clearly you're urinating often. And from our ready diagnostic criteria, we know they're going to be hyperglycemic and have a high ketone levels. Okay, what makes it really worrisome that you might think more of step down unit or ICU are the later extreme signs. Okay, so as a result of feeling extremely dehydrated and also kind of that buildup in the metabolic acidosis, people can become encephalopathic. All right. I will say though, this is more associated with type 2 diabetes just because this is more related to someone who has extremely high osmolality. I'm talking about greater than 320. So if you actually have a type 1 diabetic who's coming in with DKA, who's encephalopathic, be very concerned that there's something else going on. It's not just maybe their metabolic acidosis that's contributing to the picture. They're going to feel flushed. The nausea, vomiting, pain in the abdomen, it's kind of unclear as to why this occurs. Some people say it might be related to the metabolic acidosis that causes delayed gastric emptying. And you have to compensate somehow for this build of metabolic acidosis. So instead, what you do is that you try to breathe it off with CO2. So a very classical board finding you might know is the Kussmaul breathing. So that's that really deep, rapid inspirations and expirations. That's just making the patient try to expel all that CO2 to try to compensate for that significant acidosis. So, with DKA, I get excitement when I ultimately treat it, whether it is at a hospital that doesn't have their own DKA protocol where I have to take maybe a couple hours to really instruct the nurses to do it. And I want to pat myself on the shoulder. But what you really need to know, though, is that DKA doesn't just happen, okay? It's a sequela. There's something, some kind of inciting factor that ultimately caused the DKA. As internal medicine, treating is the easiest thing. What our job is actually finding out why. Why is the DKA happening? So what my ICU attending taught me, he called it the 8 I's. Okay, so first, infection. Is this patient, as you Lee said, having some kind of viral infection, gastroenteritis, pneumonia, UTI, very common? Second I, infarction. A patient comes in, they're encephalopathic. It's an elderly gentleman, so they have coronary artery disease as a result of an MI. Infraction, unfortunately with Miss Sydney Sweet, she was non-adherent to her insulin, which obviously can cause it after a couple days. Infancy, pregnancy-related complications. Ischemic, CVAs, illegal, substance abuse, so cocaine, methamphetamines, iatrogenic. Is it from us? Is it someone coming in for a COPD exacerbation and we're giving them steroids or we're treating some kind of, autoimmune issue, and those steroids is causing a really uptake in their glucose control. And lastly, idiopathic. It can just happen, especially more think of elderly patients, bored, really styled questions. If they have other autoimmune issues going on, if they have hypothyroidism, for instance, adrenal insufficiency, typically autoimmune issues kind of like to pair up. So now thinking of, again, going back to pathophysiology, what labs do you all want to get? Okay, so far you hear about her history. You hear, I told you she's not pregnant, okay? But she's just saying that. What labs do you want to get?
I still want a pregnancy test on her.
You'll
Like I'm
never
gonna get
go
urine
wrong.
anyway, so I might as
Uh-huh.
well just get a pregnancy test too.
You'll never go wrong. That would be the easiest thing. What else?
CBC, CMP.
Okay. High yield stuff. Anything
Yep.
else?
Um, a mag and a
Mac, okay.
FOS. And is your facility available to do a beta hydroxy?
It absolutely is.
Okay, because in Alaska we can't.
Oh, I'm sorry.
Yeah.
Well,
So,
it's okay. Don't worry, our facility has it.
okay, so then I want that too.
Okay, right on. Okay, so let's see what we got here. Okay, so typically a lot of these labs that EED that ultimately gets it, but UA it showed she has ketonuria. Okay, this spec grav of 1.030 that on the higher end clearly shows that she's pretty dehydrated. The ABG shows she's acidotic. Her pH is less than 7.3. It's currently at 7.15. Bicarb less than 15. Okay, it's currently at 10. She's currently, you would expect maybe Kussmaul breathing, right? Her PaCO2 is on the lower end. She's probably trying to rapidly expel as much CO2 as possible to compensate for that metabolic acidosis. That renal function panel or CMP, it's showing right now a creatinine 1.8. Her baseline's 0.8. Clearly, this might be more pre-renal. She's dehydrated. Okay. And we're actually seeing the hyperglycemia 450. Potassium looks okay. It's currently 5, but we'll talk about that a little bit later during treatment. CBC, she's clearly stressed. She has leukocytosis of 18,000. And as a result of dehydration, you can clearly see she's hemoconcentrated. Her hemoglobin is currently 15.2. She's high serum osms, 300. That beta hydroxybutyrate that thankfully we're able to attain is elevated. It's greater than 3. She is negative for her pregnancy test. And, any ED physician, you come in, they have abdominal pain, they get a lipase. And it's not wrong. Lipase, thankfully, in this situation was normal. And she has a mildly elevated lactic acid, which is very common for patients that come with DKA. So something really important to know that I wish I learned way earlier, I feel like I would have actually been able to flex a little bit if I was a medical student for this, is beta hydroxybutyrate is the most predominant ketone in DKA. That's why we get it. That's why we actually have the assay for it. And in terms of the urine serum ketones, that actually we can get instead, if let's say we don't have the beta hydroxybutyrate, that only detects the acetic acid and acetone, not beta hydroxybutyrate. So just keep that in mind. So beta hydroxybutyrate is a lot more not only sensitive but specific for DKA. So how do you want to manage this patient? Any takers?
Either I'm the only medical student left or no one else wants to.
Megan, I think you're sending it right now.
Yeah, so
Oh, there's
insulin
we got one,
and
insulin and potassium. But go on,
yeah,
Megan.
their pH is less than 7.2, but
Mhm.
are they actually hemodynamically unstable? Like I didn't see like a blood pressure or anything.
No, thank you for asking. She is thankfully hemodynamically stable, kind of in the lower limit of normal for her. I would
Okay.
say, let's say 110 over 70.
Well, then I would probably just do like an amp of bicarb.
Okay. So we'll talk about that in a moment regarding with the bicarb. But in terms of management, I will say, so most important thing that you should get out of this lecture is fluids, 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 and maybe a little extra fluids. Okay. If you think about it, again, patients have a huge, they're very volume depleted, very hypovolemic. Okay. Again, we typically are seeing them when they're approximately 6 to 8 liters down. Okay. And we'll talk about it in a second. While we're doing this, we're always going to replenish electrolytes, most notably potassium. And of course, we're going to give insulin. And another key point I want you to get out of this is that insulin is not actually meant for the treatment of the hyperglycemia. Okay. It's meant to treat the metabolic acidosis. Okay. Because if you think about it, insulin, kind of like we were going back with the pathophysiology, it's allowing glucose to enter the cell, and that will disinhibit those fatty acids from ever getting broken up and contributing to the acidosis. Okay, so I found a wonderful chart here that kind of, gives the broad strokes of how we manage for DKA. Obviously, though, beforehand, you asked about their vitals. So, of course, we want to think about the ABCs before we even do anything. If Miss Sydney Sweets came in obtunded, unable to protect her airway, as much as I want to treat instantly, I'm going to need to intubate her. I'm going to probably put her in the ICU. If, let's say, she's extremely hypotensive, I'm not able to give enough fluids, I'm probably even going to have to consider a vasopressor to actually at least temporize and elevate her blood pressure while we're treating her. So, talking about the most important thing first is the fluids. Okay. So, again, most patients are going to be hypovolemic. Okay. What we typically would do is that within the first couple hours, I would say it would be about 1,000 cc per hour for the first couple hours. Okay. And most notably here, you'd see that it's going to be an isotonic fluid. So either normal saline or I prefer personally lactated ringers. Okay. Why? It's just because people are not only dehydrated, it's almost like they have hyperosmolar dehydration. If we give them more of a hypotonic fluid, we don't want to correct them too quickly. This is actually kind of a great lecture following up the hyponatremia lecture. It's just the opposite end. Once patients are a little more euvolemic, and let's say their sodium is at a more reasonable level, we can consider more of the hypotonic fluids, half normal saline, and just keep it running for them. And then once insulin's working its magic and the glucose is going down, we obviously don't want to tank them, so we just slap on some sugar water into that fluid just to keep it at bay while we're correcting the acidosis. Now, going down here, you're seeing the potassium. So think about it. So Miss Sydney Sweets, she actually had a potassium of 5. That seems like a good amount, but think about it. So first off, she had, let's say a random number. She's 6 liters down. Okay, she had a pretty significant amount of diuresis. So obviously she's peeing out a lot of potassium. Okay. Secondly, because of metabolic acidosis, think about the shifting. All right, protons and basically protons are going to come into the cell, exchange for potassium. So potassium is going to go out into the serum and ultimately also get excreted through the urine. And lastly, when people have such a so hypovolemic, you think of things like secondary hyperaldosteronism, where your kidneys are doing everything it can to retain fluid. So it's going to keep in the sodium and unfortunately expel potassium. So although it shows that she has a potassium of 5, she might be severely low. And so if I were to treat them with insulin, giving them fluids, I'm probably going to expect a pretty significant drop in their potassium. So that's why here, I would say right off the bat, let's say if the patient called you, well, the ED called you, and her potassium's less than 3.5, do not start the insulin yet. I want you to be able to get about 40 to 80 milliequivalents to get above that level, just so we make sure we don't tank the patient of their potassium, which ultimately could cause arrhythmias and a lot worse situations than just the simple things like this acidosis I've been telling you about. And then typically the range between 3.5 to 5, we're slapping on about 10 milliequivalents per hour with our fluids that we talked about above there. So insulin, I'm not going to go too into depth. I will say hospitals have their own DKA protocol. Okay. Typically, though, what you would do is at zero point 0.1 units per kg per hour. And then from there, based on their glucose levels, it gets titrated. The most important thing I want you to know, though, for the purposes of when someone's getting off insulin drip is that the insulin drip is short-acting insulin. Okay, so if I turn it off, I want to make sure there's something covering her. Okay, Miss Cindy Sweets, because what happens is that if now she's off insulin, there could be a recurrence of her DKA. She might become acidotic again. So typically, before I turn off the actual drip, I'm going to give them subcutaneous insulin, most notably long-acting, just to make sure that's carried over for her. So we're not going to discuss this. This actually just shows you an example. This is actually my hospital's DKA protocol. It's very complex. I would say a lot of nurses, though, know it. And at the same time, too, I want you to know it. The biggest, I feel like, what makes you look good as a medical student is, let's say, if an attending were to tell you, how do you want to treat this DKA? Never say DKA protocol. Okay. Talk about the actual things that go behind it, the insulin, the potassium, the fluids. And then knowing this too will be very useful as a resident for you, just because, sometimes it might be a fresh nurse. They won't know what to do yet. They're not actually trained as of yet. And that's very common and that's okay. And our role in ourselves, we should know this ourselves because we're ultimately the ones in charge of the patient. So this point now, let's say her DKA resolved, she transitioned to subcutaneous insulin. She's ready to go. She gives you a thumbs up. She actually really wants to go because she needs to work. She actually probably has a shift later than that day. Any instructions you want to give to her?
Take her insulin as prescribed.
That is a very high yield thing. Okay. Yeah. So what I would say is, of course, there's strict return precautions. Absolutely, she should take her insulin. Okay. What I would say as well is by teaching her those symptoms, always, she'll now know when to contact the healthcare team early, just see whether or not she should go into the ED. And secondly, one should never really discontinue their insulin. It could be understandable. I wouldn't give her too much of scrutiny just because, she might have actually thought, well, I'm not eating much. I shouldn't be taking my insulin. It might be her way of thinking, okay, this is actually a good thing. But you should never do that. You should always just reduce because just a little bit of insulin, as we clearly can see in our pathophysiology, that prevented fatty acids from ever getting broken down. Also, I would tell them increase their finger sticks, make sure you're actually monitor more when you're actually feeling sick. If you have a fever, use antipyretics, Tylenol, just because by having a fever, you're increasing your metabolic demands, which also make you more prone into flipping into DKA. Drink lots of fluids. And again, not only educating the patient, but let's say her boyfriend, for instance, let's say family. What are those signs that if she does become very sick, they can also prompt her to go into the ED? And lastly, remember, we're DOs, okay? We think holistically. What is going on with Miss Sydney Sweets? Is it because of finances? Is she not making enough money in the diner where she's able to afford maybe was the appropriate healthcare? She's on a very small dose of the escitalopram. Is she actually experiencing is she subtherapeutic on her depression? Is she scared of needles? It is a very, it's a lot of burden that these patients experience. Does she have the right support? Can you see in the top right? Is her boyfriend there? Is she the one that actually gives the insulin? Thinking those things as a whole, ultimately, we care about treatment, but I want to make sure that when I actually discharge a patient, I never want to see them back. Common thing I would tell them is I look forward to seeing you at a cafeteria in the hospital rather than the patient bed. So clinical pearls, of course, again, know your hospital DKA protocol. I implore you to go look it up. It's always accessible through most EMRs, or you can just ask the nurses because most floors will have it equipped for them. And again, never just say DKA protocol as your answer when you're treating for it. Fluids, fluids, fluids. That's the biggest thing. And lastly, always think about the etiology. What's the inciting factor? A last little chime in to give you a perfect example. We had a patient who they were a transplant patient. They had a new kidney. They were running one day and they became encephalopathic. They were admitted. They were found to actually they were on Jardiance. They found to have euglycemic DKA. And they were treated for it. I was in the ICU, and by the time that ultimately she was transferred, this was after, I'd say, 15 hours. She actually had gram-negative bacteremia, and she wasn't started empirically on antibiotics. So ultimately, she passed as a result of that. So know very well of things that can cause it, because by treating that problem, ultimately you're treating the DKA. So here's just my references. Does anyone have any questions?
Good time for questions. So while they're dreaming up questions, Dr. Arthur, once you start IV insulin, how long are you going to use it?
How
What's
long are
your
you going to typically?
what's your
Yeah.
stopping point?
So the stopping point, thank you for bringing that up. The stopping point is when I resolve the acidosis. So typically once the anion gap is closed is when I'm going to feel prompted that I can stop or at least transition to the subcutaneous insulin.
Well, that sounds like a board question to me.
That is a very high yield board question.
Yeah. Any other questions? I'm glad that you didn't get into the argument of lactated ringers and normal saline, because for the last 50 years we've been arguing this case, and we have two nephrologists online, so it could get to be really hot. So I'm not gonna. Glad you didn't go there.
It's my pleasure. Let's see here.
If you're ventilating this patient, you take him for ventilation. What are you doing with the ventilator? What are you trying to
S-
achieve?
so if I'm putting them on the ventilator,
Mhm.
um, are you talking
What
about
Yeah, what are you
inducing
trying?
more? Go on.
Go ahead.
Oh, yeah. My question for you is that are you talking about increasing respiratory rate to help compensate?
Yeah, how do you use the ventilator to help support your treatment of of your DKA?
Yeah, so what I can do is either one, I can increase the respiratory rate. If they're breathing above the vents, I can consider the actual tidal volume, or whether it's tidal volume or pressure. Just see if I can help by increasing that to expel more CO2 off.
Okay. Right, what type of pH are you trying to achieve with the ventilator?
Um, the thing is, I would personally, I don't want to cause too much of a correction, just because what's going to happen is if I'm already giving insulin and I have a pH goal of, let's say, greater than like to 7.4, that might not be too well. I would say above greater than like 7.2, to be honest. I don't know what your thoughts are, Dr. Good.
And I think, just as Dr. Levy was talking about, overcorrection in a lot of things we do in medicine causes more harm than good.
Hmm.
So, yeah. Dr. Levy, you have any thoughts about that?
Well, I agree 100%. I think we often do a lot of things that we maybe shouldn't be doing so much, and I see a lot of that, unfortunately, and we tend to cause a lot of problems when we're trying to help, but sometimes the best thing to do is just let things go as they are.
Excellent review of pathophysiology, John. And I hope the students take that to heart, because it's knowing the pathophysiology will get them through a lot of board questions coming up.
Yep.
That's true of both topics tonight. And of course, these topics overlap significantly. Any other questions or comments, students, faculty?
Uh, Actually, I want to bring up one thing, Megan. You actually asked about a kind of important topic that everyone has in the back of their mind. Should I give bicarb to the patient?
Oh, yeah,
Um,
good.
yeah, what I would say is, so of course, bicarb is typically not common when you're treating DKA, because ultimately when you're resolving the acidosis just with insulin alone. And actually, if you think about it, if you give bicarb to someone, what happens is if they're not properly ex it can convert to CO2. And ultimately what happens is, let's say they're obtunded and they're not really breathing as well, you actually could inadvertently worsen their acidosis. It's try and true. If they're on the ventilator, that could be something you consider. I would say less than a pH of 7. But even then, a lot of critical care physicians are hesitant about doing that.
Yeah,
Yeah,
thank you for saying it. Yeah, David, go ahead.
I would just add that we've really moved very away from using bicarb. It's really rare For exactly those reasons. You can actually cause an intracellular acidosis. And if you're giving bicarb, if they have normal kidney function and you're treating the DKA, this is going to go away. If they don't have normal kidney function or it's a dialysis patient, then we're going to dialyze them. And if they have severe acute kidney injury and they're not making urine, then same story, they're going to get dialyzed. So it's really rare outside of a code. I can't remember the last time I recommended giving an amp of bicarb just straight for something like this. It's just usually more harm than good.
Yeah, that's a really excellent point, guys. And again, that's one of the things that through the years we hopefully have learned.
I guess it's just the Wild West up here.
But you thought about something, and I actually appreciate that. It's and again, everyone has in the back of their mind, especially when someone ultimately gets even to the ICU. It's something you always, I even thought about it plenty of times when someone had DKA.
Yeah, that's where I've seen it is out here in the ICUs.
Yep.
I think as we go through, and this is just an editorial comment from a bad editor, as we go through life, we have to go back to best practice standards and see what the medical literature is supporting. And a lot of the old, a lot of the past thoughts processes get changed as we go through things. And in the last 40 plus years that I've practiced, we've gone through cycles of this. And right now, as these guys have said, bicarb is something we really don't want to push. There's a lot of complications that come as a result. And even in the ventilated patient, I can do a lot with a ventilator to help improve acid base status. I think as students, one doesn't argue with your attending, but one can certainly take can certainly take articles. And today with the medical literature search being so available, and I have my students, they want to argue with me. I'm happy to do that, but bring me the article and let's really dive into the article and try to decide and decipher what that article is really saying. Any other comments from our speakers? Thank you both very much. I think these are excellent presentations. Tim has got this and Kara on video tonight. I think we can send these out to programs. As to the students, if you can get some of your colleagues to take a look at these videos and listen 30 minutes at a time. And maybe you got a patient with DKA right now, you can learn from this, and every day we have somebody with hyponatremia. That's a daily event. So the next topic we have will be in April. We are speaking about COPD and congestive heart failure. We have two excellent faculty members to present during that time. Any other questions or comments from students, faculty? If not, thank you so much for joining us tonight and have a great week.